If you are taking vitamin D every single day and you are doing it the way most people do it, I need you to stop for a moment and listen carefully. Not stop taking vitamin D. Stop taking it the way you have been taking it. There is a difference, and that difference matters more than almost anything else I could tell you today. Here is what is happening in millions of homes right now. Somebody opens a bottle, shakes out a soft gel, swallows it with a sip of water, and moves on with the morning. They have been doing this for 2 years, maybe 5 years, maybe longer. They feel fine about it. They believe they are protecting their bones, their immune system, their mood, their heart. And in many cases, what they are actually doing is either wasting their money completely or slowly setting up a problem inside their arteries that will not announce itself for a decade. I know how that sounds. I am not here to frighten you, and I am not here to tell you that vitamin D is dangerous. Vitamin D is one of the most important compounds in the human body. What I am telling you is that vitamin D does not work alone. It never has. And when you take it alone, in isolation, without the partners it needs, you are not getting what you paid for. Worse, you may be pushing your body in a direction you never intended. So let me walk you through this properly. I want you to hear the whole explanation because once you understand the mechanism, you will never take a vitamin D capsule carelessly again. And by the end of this, I am going to ask you a question, and I want you to be honest with yourself when you answer it. Let me start with why so many of us are taking vitamin D in the first place. Vitamin D is not really a vitamin. That is the first thing almost nobody knows. It behaves like a hormone. Your body manufactures it in the skin when ultraviolet B light strikes a form of cholesterol sitting in your skin cells. From there, it travels to the liver, then to the kidneys, and it gets converted twice before it becomes the active compound your cells can actually use. That active form then goes on to influence somewhere in the range of 200 to 1,000 different genes, depending on which researcher you ask. It touches bone building, it touches immune regulation, it touches muscle function, insulin sensitivity, blood pressure regulation, and mood. And most of us do not have enough of it. Look at how we live now. We wake up indoors. We drive to work inside a metal box with tinted glass. We sit under fluorescent light for 8 or 9 hours. We drive home. We eat dinner indoors. We watch television indoors. If we do go outside, many of us apply sunscreen first, which is a reasonable thing to do for skin cancer prevention. But it also blocks the exact wavelength that makes vitamin D. Add in the fact that skin over the age of 65 produces roughly a quarter of the vitamin D that young skin produces from the same amount of sun exposure. Add in darker skin tones, which need considerably more sun time to make the same amount. Add in living above the 40th parallel, where from about October to March the sun simply does not sit high enough in the sky to deliver usable ultraviolet B at all. So we supplement. That is the sensible response. I have no argument with supplementing. The argument starts with how. Here is the first mistake, and it is the one that quietly ruins everything else. You are taking vitamin D without magnesium. I want to explain exactly why this matters, because when people hear this, they usually think I am just recommending another supplement to buy. I am not. This is not a preference. This is biochemistry. And it is not optional. When you swallow vitamin D, Whether it comes from a capsule or from your skin, it is inactive. It cannot do anything yet. It is a raw ingredient. Your liver has to take that raw ingredient and convert it into a compound called 25-hydroxyvitamin D. That is the storage form. And by the way, that is the exact thing your doctor measures when you get a vitamin D blood test. Then your kidneys take that storage form and convert it a second time into 1,25-dihydroxyvitamin D, which is the active hormone. Only that final form does the work. Both of those conversion steps depend on enzymes. And every single one of those enzymes requires magnesium to function. Read that again. Every enzyme in the vitamin D activation pathway is magnesium dependent. It goes further than that. The protein that carries vitamin D through your bloodstream, called vitamin D binding protein, needs magnesium to do its job properly. And there is an enzyme responsible for breaking down and clearing excess vitamin D. And that one is magnesium dependent too, which means magnesium is involved on both ends of the process, activation and regulation. So picture what happens when a person who is low in magnesium starts taking 5,000 international units of vitamin D every day. The vitamin D goes in. It sits there. The conversion machinery is understaffed. Some of it converts, slowly and inefficiently. The rest accumulates in an inactive state. The person comes back 6 months later, gets a blood test, and the number has barely moved. Or it moved a little, but they feel exactly the same as before. No more energy, no better mood, nothing. And what do they usually do at that point? They increase the dose. They go from 5,000 to 10,000, which does not fix the bottleneck at all, because the bottleneck was never the amount of vitamin D. The bottleneck was the magnesium. There is research from Vanderbilt University suggesting that magnesium supplementation actually changes the way the body handles vitamin D. And interestingly, it seems to push levels in whichever direction the person needs. People who started low tended to rise. People who started very high tended to come down. That is what a cofactor does. It does not force a number up. It restores the regulation. Now here's the part that makes this urgent. Magnesium deficiency is not rare. It is closer to normal. Depending on which national survey you look at, somewhere around half of adults in the United States take in less magnesium than the recommended amount from food. Some estimates run higher than that. Why? Several reasons stack on top of each other. Agricultural soil has been depleted of magnesium over decades of intensive farming, so the same vegetable your grandmother ate carries less of it today. Food processing strips it out aggressively. When wheat is refined into white flour, most of the magnesium leaves with the bran and germ. Same story with white rice, same story with refined sugar. Then there are medications. Proton pump inhibitors, the acid reflux drugs that millions of people take for years at a time, are well documented to lower magnesium. Certain diuretics, the water pills prescribed for blood pressure and heart failure, flush magnesium out through the urine. So do some antibiotics and some chemotherapy agents. Then there is alcohol, which increases magnesium loss through the kidneys, and chronic stress, which does the same thing, because when cortisol is elevated for long stretches, magnesium excretion goes up. And here is the cruel part. A standard blood test will usually not catch it. Only about 1% of the magnesium in your body is floating in your blood serum. The rest is inside your bones and inside your cells. Your body will strip magnesium out of bone to keep blood levels steady because blood magnesium affects heart rhythm, and the body will not tolerate it drifting. So you can have a perfectly normal serum magnesium result while your tissue stores are running on empty. Your doctor sees normal, your cells do not agree. So what does this look like in a real person? Muscle cramps, especially in the calves at night. Eyelid twitching, that flutter under your eye that comes and goes for weeks. Constipation, difficulty falling asleep or falling asleep fine, and then waking at 3 in the morning with your mind racing. Anxiety that has no obvious cause, headaches, heart palpitations, restless legs. If several of those describe you, and you are also taking vitamin D daily, you now have a possible explanation for why the vitamin D never seemed to do much. Let me tell you what to do about it. Practically, start with food, because food is always the better foundation. Pumpkin seeds are exceptional, roughly 150 milligrams of magnesium in a single ounce. Almonds and cashews are strong. Spinach, chard, and other dark leafy greens carry a good amount. And there is a nice logic to that, because magnesium sits at the center of the chlorophyll molecule, which is why those leaves are green in the first place. Black beans, chickpeas, and lentils. Avocado. Dark chocolate at 70% cacao or above, which is the rare piece of nutrition advice that people are actually happy to receive. Fatty fish like mackerel and salmon. Whole grains, real ones, not the refined versions. If you are going to supplement, the form matters enormously, and this is where a lot of money gets wasted. Magnesium oxide is the cheapest form and the most common one on discount shelves. Its absorption is poor, often cited around 4%. Most of it passes straight through, which is precisely why it works as a laxative. If your bottle says magnesium oxide and you bought it because it was inexpensive, you now know why it did not help. Magnesium glycinate is bound to the amino acid glycine. It absorbs well, it is gentle on the digestive system, and glycine itself has a calming quality, which is why this form tends to be recommended for people whose main complaints are sleep and anxiety. Magnesium citrate absorbs well and is a good general choice, though it moves the bowels more, which some people want and some people definitely do not. Magnesium malate is bound to malic acid, which is involved in cellular energy production, and it is often suggested for people dealing with fatigue or muscle pain. Magnesium threonate is the form studied for crossing into the brain, and it is the expensive one. Typical supplemental doses fall in the range of 200 to 400 milligrams of elemental magnesium daily. And I want you to notice that phrase, elemental magnesium, because a capsule labeled 1,000 milligrams of magnesium glycinate might only contain about 140 milligrams of actual magnesium. The rest is the glycine. Read the label carefully. Now the caution, and please do not skip this one. If you have reduced kidney function or you are on dialysis, magnesium supplementation can be genuinely dangerous because your kidneys are what clear the excess. Magnesium builds up in that situation. If you have any kidney disease at all, you do not add magnesium without your doctor's involvement. Full stop. That is mistake number 1. Here is mistake number 2, and honestly, this is the one that concerns me most, because the first mistake wastes your money, while the second one may cost you something you cannot buy back. You are taking vitamin D without vitamin K2. Let me explain what vitamin D actually does with calcium, because I think most people have this backwards. Vitamin D increases calcium absorption from your intestines. That is one of its primary jobs. Without adequate vitamin D, you absorb maybe 10 to 15% of the calcium you eat. With adequate vitamin D, that figure can climb to 30 or 40%. So, vitamin D opens the door and lets calcium into your bloodstream in much larger quantities. Good. That is what we wanted. But now ask the obvious follow-up question, the one almost nobody asks. Once the calcium is in the bloodstream, what tells it where to go? Because vitamin D does not do that. Vitamin D is the doorman. It gets calcium into the building. It does not decide which floor calcium ends up on. And calcium has options. It can go into your bones and teeth, which is where you want it. Or it can settle into the walls of your arteries, into your kidneys, into your heart valves, into soft tissue where it has no business being. The thing that directs traffic is vitamin K2. Here is the mechanism, and it is elegant once you see it. Your body produces two proteins that manage calcium. The first is called osteocalcin, and it is made by the cells that build bone. Its job is to grab calcium out of the bloodstream and lock it into the bone matrix. The second is called matrix Glay protein, and it sits in the walls of your blood vessels and in cartilage. Its job is to actively prevent calcium from depositing where it should not. Both of those proteins are manufactured in an inactive state. They do not work when they are first made. To switch them on, they need to undergo a chemical modification called carboxylation, and the only nutrient that can drive that reaction is vitamin K. No vitamin K2, no activated osteocalcin. Calcium does not get pulled into bone efficiently. No vitamin K2, no activated matrix GLA protein. Nothing stands guard over your arteries. So now, put the whole picture together. You take a high dose of vitamin D. Calcium absorption goes up substantially. More calcium enters the bloodstream. And the two proteins that are supposed to escort that calcium to the right destination are sitting there inactive because there is not enough vitamin K2 to switch them on. Where does the calcium go? Wherever it wants. This is what people mean when they refer to the calcium paradox. And it has a real observational footprint. There is a long-running study out of Rotterdam in the Netherlands that followed roughly 4,800 adults for about 10 years. And the people with the highest dietary intake of vitamin K2 had substantially lower rates of arterial calcification and lower cardiovascular mortality compared to those with the lowest intake. Vitamin K1, the form found in leafy greens, did not show the same relationship. I want to be straight with you about the strength of that evidence because I think you deserve honesty rather than a sales pitch. Rotterdam was an observational study. It shows an association. It does not prove that K2 caused the difference. And there are randomized trials on vitamin K supplementation that produced mixed and sometimes disappointing results, particularly in people who already had significant arterial disease. The science here is suggestive and biologically coherent, not settled. But here is my position, and I will tell you exactly how I arrived at it. The mechanism is well established. The proteins are real. The carboxylation reaction is real, and the vitamin K dependency is not disputed. Most people take in very little K2 from their diet. And unlike some other interventions, adding K2 alongside your vitamin D is low cost and, for the vast majority of people, low risk. So while I cannot promise you that K2 will protect your arteries, I can tell you that taking large amounts of vitamin D with no attention to K2 at all is a gamble I would not personally take. Now let me deal with something you may be thinking. You eat salad? You eat kale and broccoli and spinach? Surely you are covered. You are not. And this trips up a lot of well-informed people. The vitamin K in leafy greens is vitamin K1, phylloquinone. K1 goes almost entirely to your liver, where it is used for blood clotting. That is its main assignment. Your body can convert a small fraction of K1 into K2, but the conversion is inefficient and unreliable, and it varies enormously from person to person. Vitamin K2, menaquinone, comes from fermented foods and from certain animal products. And that is exactly where the modern diet fell apart. The richest source on the planet is natto, a Japanese fermented soybean dish. One serving contains a staggering amount of the MK7 form. It also has a texture like sticky glue and a smell that most people outside Japan find genuinely challenging. I am not going to pretend otherwise. If you can eat it, it is unmatched. Most of you will not. After that, look at aged and hard cheeses. Gouda, Edam, Brie, Jarlsberg, and Swiss carry meaningful amounts, produced by the bacteria used in the fermentation. Egg yolks from pasture-raised hens, not the pale yolks from caged birds. Grass-fed butter and ghee. Goose liver, if that appears on your table. Chicken thighs and dark meat. Sauerkraut, that is genuinely fermented and unpasteurized, not the vinegar-pickled version sitting in a shelf-stable jar. Notice a pattern. Fermented foods and full-fat animal foods from animals that ate actual grass. Those are the two categories the past several decades of dietary advice pushed hardest against. We were told to avoid butter, avoid egg yolks, avoid full-fat cheese, avoid organ meats. And in doing that, we quietly removed most of the vitamin K2 from the Western diet, at the same time that vitamin D supplementation became universal. If you choose to supplement K2, there are two forms you will see on the label. MK4 has a very short half-life in the blood, on the order of a few hours, so it requires frequent dosing, and it is typically studied at high doses, often 45 milligrams daily, in Japanese bone research. MK7 comes from bacterial fermentation and has a much longer half-life, roughly 3 days, which means a single daily dose keeps blood levels steady. This is the form most commonly paired with vitamin D in combination products. Common doses run from about 90 to 200 micrograms daily. Note that those are micrograms, not milligrams. Now the warning, and this one is not optional, so please pay attention. If you take warfarin, which some of you may know by the brand name Coumadin, you must not start vitamin K2 without speaking to the doctor who manages your prescription. Warfarin works by blocking vitamin K. That is its entire mechanism. Adding vitamin K directly opposes the drug and can throw your clotting values out of range, which is a serious matter in either direction. It is not that K2 is forbidden for warfarin patients in every case, because some physicians actually use small, consistent doses to stabilize erratic readings. But that decision belongs to your doctor with monitoring, not to you and a bottle from the pharmacy shelf. The newer anticoagulants, the ones like apixaban and rivaroxaban, do not work through vitamin K, so the interaction is different. Even so, if you are on any blood thinner at all, ask first. That is the rule. Ask first. Now let me move to mistake number 3, which is far simpler than the first two, but catches an enormous number of people, you are taking your vitamin D on an empty stomach. Vitamin D is fat-soluble. It dissolves in fat, not in water. So when it arrives in your small intestine, it needs dietary fat present in order to be absorbed properly. Fat triggers your gallbladder to release bile. Bile emulsifies the fat into tiny droplets. Vitamin D dissolves into those droplets, gets packaged into structures called micelles, and only then can it cross the intestinal wall and enter your system. No fat, no bile release, poor micelle formation, poor absorption. It is that mechanical. So the person who takes their vitamin D first thing in the morning with a glass of water before eating anything and then has black coffee and heads out the door is absorbing a fraction of what is in that capsule. Not zero, but considerably less than they think. There is a well-known piece of clinical observation from the Cleveland Clinic on this. They studied patients whose vitamin D levels would not rise despite steady supplementation, and simply instructing them to take the supplement with their largest meal of the day produced an average increase of roughly 56% in blood levels after 2 to 3 months. No change in dose, no change in brand. Same capsule, different timing. 56% from one instruction. So what counts as enough fat? You do not need a large meal. Research suggests something in the range of 10 to 15 grams of fat is sufficient to do the job. That could be a whole egg cooked in a little butter, a quarter of an avocado, a small handful of nuts, a spoonful of olive oil on your salad, a piece of salmon, full-fat yogurt, cheese. And here is a small detail worth knowing. If you take a soft gel capsule, the vitamin D inside is already suspended in oil, usually olive oil, coconut oil, or sunflower oil. That helps. It does not fully replace a meal, but it gives you a head start compared to a dry tablet or a powder capsule, where you are entirely dependent on what else is in your stomach. There is also the question of bile. If you have had your gallbladder removed, or you have any condition affecting fat digestion, and here I mean Crohn's disease, celiac disease, chronic pancreatitis, cystic fibrosis, or a history of bariatric surgery, your absorption of all fat-soluble vitamins is compromised. That includes vitamin D. If that describes you, this is a conversation to have with your physician, because you may need higher doses or a different delivery form, and you definitely need your levels checked rather than assumed. There is one more thing on this point. Some people take their vitamin D with a full glass of water and nothing else because they have been told to take supplements with water. That instruction exists for pill safety, so tablets do not lodge in the esophagus. It was never intended as advice about absorption. Water helps the capsule go down. It does nothing to help vitamin D get in. That brings me to mistake number 4. And I want to handle this one carefully because there is a lot of confident advice circulating about it that runs well ahead of the evidence. You may be taking your vitamin D at the wrong time of day for your body. Here is what I can tell you with confidence. A large number of people report that when they take vitamin D in the evening, particularly at a higher dose, their sleep gets worse. They lie awake. They feel wired. They wake up repeatedly. And when they move the same dose to the morning, the problem disappears. Here is what I cannot tell you. I cannot tell you this is proven because the controlled research on vitamin D timing and sleep is thin and inconsistent. Some studies find no effect at all. There is a proposed explanation that makes biological sense. Your body naturally produces vitamin D during daylight, from sunlight, and melatonin is released in darkness. The two are, in a rough way, opposites on the daily clock. So the reasoning goes that introducing a large signal of vitamin D at 10 in the evening sends your system a message that conflicts with the one it is trying to send. There is some laboratory work pointing to an interaction between vitamin D and melatonin production. Whether that translates into your actual sleep is another question. So rather than tell you what to do, let me tell you how to find out. Take your vitamin D with breakfast or lunch, whichever meal contains real fat, for 2 weeks. Pay attention to how you sleep. If nothing changes, timing is not your issue, and you can stop thinking about it. If your sleep improves noticeably, you have your answer, and it costs you nothing to discover. There is a practical argument for morning dosing anyway, which has nothing to do with sleep. Consistency. People who take a supplement at breakfast remember to take it. People who plan to take it at bedtime forget, or fall asleep on the couch, or take it 3 nights out of 7. A supplement you actually take beats an optimally timed one you skip. Now, let me get to the 5th mistake, and this is the one where the risk stops being theoretical. You are taking a high dose without ever having your blood tested. I want you to think about how strange this is. If your doctor prescribed a medication that acts on hundreds of your genes, affects your calcium metabolism, accumulates in your fat tissue, and can build up over months, you would expect monitoring. You would expect a follow-up. Nobody would hand you an open-ended prescription for a hormone and say, take whatever seems right, indefinitely, and let us never check. But that is exactly what happens with vitamin D, because it sits on a supermarket shelf next to the vitamin C. The test you want is called 25-hydroxyvitamin D. Sometimes it appears on the lab form as 25-OH vitamin D. That is the storage form I mentioned earlier, and it reflects your true status over the previous weeks. There is a second test that measures the active form, and it is generally not the right test for assessing whether you have enough. So if a lab hands you that one, ask. Reference ranges vary between laboratories and between medical bodies, and the disagreement is real, not a technicality. Broadly, results below 20 nanograms per milliliter are treated as deficiency by most authorities. Between 20 and 30 is commonly labeled insufficient. 30 to 50 is the range most clinicians are comfortable with. Above 100, the concern about toxicity becomes serious. Some functional medicine practitioners prefer to see levels in the 50 to 80 range, while more conservative bodies argue that going above 30 offers no demonstrated additional benefit. I am telling you about that disagreement rather than hiding it, because you may hear both positions and wonder who is lying to you. Neither is. They weigh the same evidence differently. Now, actual vitamin D toxicity is rare. I want to be fair about that. It is not something that happens to a person taking 1,000 or 2,000 international units a day. It generally requires very high intakes, sustained over long periods, often 10,000 international units daily or more for months, and most documented cases involve either a manufacturing error, a dosing mistake, or somebody deliberately mega-dosing on the basis of something they read. But rare is not never, and the cases that do occur are unpleasant. What happens is that the excess vitamin D drives calcium absorption up, and blood calcium climbs above the normal range. That condition is called hypercalcemia, and the symptoms are miserable, and worse, they are vague enough that people often blame something else entirely. Nausea and vomiting, loss of appetite, constipation, extreme thirst, the kind where you drink and remain thirsty, frequent urination, including getting up several times at night, muscle weakness, bone pain, which is a particular irony given why the person started taking it, confusion, disorientation, and in older adults sometimes something that looks like sudden cognitive decline, irregular heartbeat, and over the longer term, kidney stones and kidney damage, because your kidneys are the organ working hardest to clear the excess calcium. I have heard of people who had those symptoms for months, who saw more than one doctor, who went through testing for other conditions, and nobody thought to ask about supplements because the patient did not consider a vitamin worth mentioning. So tell your doctor everything you take, not just the prescriptions, the vitamin D, the magnesium, the fish oil, the turmeric, all of it. Bring the actual bottles if it is easier. That is not being difficult. That is giving your physician the information required to help you. There are also people for whom vitamin D supplementation requires genuine medical supervision rather than a casual decision, and I want to name them clearly. If you have sarcoidosis, tuberculosis, histoplasmosis, or certain lymphomas, your body produces the active form of vitamin D in an unregulated way, outside the normal kidney control system. In those conditions, ordinary doses can push calcium dangerously high. This is not a small caution. It is a serious one. If you have hyperparathyroidism, your calcium regulation is already disturbed, and vitamin D changes the picture. If you have chronic kidney disease, both the activation of vitamin D and the clearance of calcium and magnesium are affected. If you have a history of kidney stones, particularly calcium oxalate stones, more calcium absorption is not automatically what you want. If you take digoxin for your heart, rising calcium levels increase the risk of a dangerous rhythm disturbance. If you take thiazide diuretics, they reduce calcium excretion, so combining them with high-dose vitamin D can stack calcium levels upward from both directions. If you are pregnant or breastfeeding, doses should come from your obstetric provider rather than from the internet. None of that means you cannot take vitamin D. It means somebody with your chart in front of them should be deciding the dose. Now, let me give you a few smaller mistakes quickly, because they add up. Some of you are taking vitamin D2 instead of D3. Vitamin D2, ergocalciferol, comes from plant and fungal sources and is what appears in some older high-dose prescriptions. Vitamin D3, cholecalciferol, is the form your own skin produces, and it raises blood levels more effectively and holds them more steadily. Check your label. If it says D2 and you are not taking it under specific medical direction, that alone may explain a stubborn number. For those of you who avoid animal products, there is a D3 derived from lichen, so this is solvable. Some of you are storing the bottle above the stove or on a sunny windowsill or in a steamy bathroom cabinet. Heat, light, and humidity degrade the contents. A cool, dark cupboard is a better home for it. Some of you expect results in a week. Vitamin D has a half-life measured in weeks, and reaching a stable new level typically takes something in the range of 2 to 3 months of consistent daily intake. If you take it for 10 days, feel nothing, and quit, you never gave it a chance. And this cuts the other way, too. Do not retest after 2 weeks and panic. Retest after roughly 3 months. Some of you take it every day but skip weekends, or take a large dose once a week, or take it whenever you remember. Weekly and monthly dosing schedules do exist and are used clinically, but the research generally favors daily dosing for steadier levels, and there is some evidence that very large, infrequent bolus doses, the kind given once a year, perform worse than daily dosing, and in at least one trial in older adults were associated with more falls rather than fewer. And some of you have abandoned sunlight completely. I am not asking you to burn. Skin cancer is real, and I would never tell you to ignore it. But 10 to 20 minutes of midday sun on your arms and legs before you apply sunscreen several times a week, in the months when the sun is high enough where you live, is not reckless. Sunlight also gives you things a capsule cannot, including effects on circadian rhythm and mood that have nothing to do with vitamin D at all. So let me pull all of this together into something you can act on tomorrow morning. Get tested first. Ask for the 25-hydroxy vitamin D test. Know your actual number rather than guessing. If your doctor is reluctant and you are already supplementing daily, say so directly, because that changes the reasoning. Take your vitamin D3 with the meal of the day that contains the most fat. For most people, that is lunch or dinner. If breakfast includes eggs, avocado, or full-fat yogurt, breakfast works fine. Make sure magnesium is in the picture, ideally from food, and if you supplement, choose glycinate or citrate rather than oxide, and respect the kidney caution I gave you. Address vitamin K2, either through fermented foods and quality cheese and pasture-raised egg yolks, or through a supplement in the MK7 form. And clear it with your doctor first if you take any blood thinner. Stay at a sensible dose unless a physician who has seen your blood work tells you otherwise. For most adults without a diagnosed deficiency, something in the region of 1,000 to 2,000 international units daily is a reasonable maintenance range, and higher corrective doses belong in a monitored plan with an endpoint, not a permanent habit. Retest in about 3 months. Adjust from data, not from feeling. And do not forget the rest of your life while you are optimizing a capsule. Vitamin D does not compensate for poor sleep, no movement, or a diet built out of packages. It is one input among many. I want to close by going back to where I started. The reason I made this video is not that vitamin D is dangerous. It is that we have developed a strange relationship with supplements, where we take them the way we take out the trash. Automatically, without thought, without checking whether it is doing anything. Somebody recommended it years ago, or an article said it was important, and the bottle has simply stayed on the counter ever since, getting refilled without a single question asked. That is not healthcare. That is habit wearing the costume of healthcare. Your body is not a machine where you drop in a part and walk away. It is a system of relationships. Vitamin D needs magnesium to be activated. It needs vitamin K2 to direct what it unleashes. It needs dietary fat to be absorbed at all. It needs your kidneys and your liver functioning. It needs to be measured, not assumed. Pull any one of those threads out, and the whole thing behaves differently than you expected. So here's the question I promised you at the beginning, and I want you to answer it honestly to yourself right now. Go get your bottle. Look at the label. Does it contain vitamin K2 Or is it vitamin D alone? Are you taking magnesium, or did you assume your diet covered it? Do you take it with food that contains fat or with water on an empty stomach? And when was the last time, if ever, that anybody measured your actual level? If you did not like your answers, you are not in trouble, and you have not ruined anything. You are simply in the same position as most of the people watching this. And now you know something you did not know 10 minutes ago. That is all it takes to change what you do tomorrow. Talk to your doctor or pharmacist before you change anything, especially if you take medication or live with a chronic condition. Nothing I have said here replaces the judgment of somebody who knows your history and can see your test results. This is education, not a prescription. If this explained something that had been confusing you, tell me in the comments which of these mistakes you were making. I read them, and I promise you that whichever one you name, hundreds of other people are quietly reading it and thinking, that is me too. And if there is somebody in your life who takes vitamin D every day without a second thought, a parent, a spouse, a friend, send this to them. It costs you nothing, and it might be the thing that gets them to ask a better question at their next appointment. Take care of yourself. Supplement with knowledge, not with habit. I will see you in the next one.